response to a request by Dr. Antonio Colombo in April, Dr. Osamu Kato performed CTO PCI at the Milan, New York live demonstration. It was done at Dr. Colombo's Cath Lab in Milan and was transmitted live to New York. The guide wire used was Miracle. This live demonstration provided the opportunity for widespread recognition in the United States of the existence of a guide wire effective for treating CTO. After this live demonstration, Dr. Martin B. Leon made an emphatic request to ASAHI INTECC to launch this product in the United States. However, the launch was a while later. The Miracle was in fact the first CTO wire that Dr. Martin Leon had seen. Dr. Leon did not have much experience with CTO, but of course, he and his American colleagues understood at the time that the PCI market would quickly triple or quadruple once clinical PCI treatment for CTO could begin. Knowing that a wire that could actually open CTO lesions would be revolutionary, Dr. Leon sent me a fax the day after the live demonstration asking us for help setting up sales in the US and wanting to found a New York CTO Club. Dr. Leon was under the impression that the live demonstration that Dr. Suzuki, Dr. Tamai, and I had conducted was a CTO club, and in Japan, CTO experts had organized meetings. He wanted to do the same in the US, so he faxed us asking for our help. Naturally, Dr. Leon also contacted ASAHI INTECC as well. Since I had also received one, I spoke with ASAHI INTECC, and discussions moved forward quite a bit on selling the wires in the US. Product liability law was an obstacle, though. It was not easy for ASAHI INTECC to get a foothold in the US market, and talks faded at that time in 1996. Then, about 5 years later, by which time Dr. Leon had set up an American CTO club in New York, that's when the ASAHI INTECC wires were finally launched in the US. After the live demonstration in 1996, we conducted many live demonstrations in Europe and the US, which is how we demonstrated and explained in lectures the use of wires for CTO. Then CTO wires gradually came to be known. That was the Miracle wire from Japan. Conquest was launched in Japan in March 1998 on the basis of collaborative development by Dr. Kazuaki Mitsudo and ASAHI INTECC. It had a great penetration performance with its tapered design, high tip load, and enhanced lubricity. The Conquest wire has several features. One is its high tip load. It is stiff. There are many reasons for the stiffness. One is that, unlike previous wires, the core is rounded all the way to the distal tip of the wire. Before the Conquest, the conventional wisdom on wires was that the core at the tip, the exact measurements vary, but for a few centimeters from the distal, the core had to be flat rather than round. It was round through the rest of the wire, but for a few centimeters at the tip, it would be flattened to create a flat line. This was the conventional wire structure. Creating a flat tip made it possible to achieve both wire flexibility and transmit torque to the distal tip. That is one of the structures that the American wire manufacturers came up with. It became the typical wire structure common around the world. The structure was not adopted to Conquest wire, and the core was rounded all the way to the tip of the wire. Flattening the core made it possible to transmit torque to the tip and also achieve flexibility. Miracle has the same structure. However, there was also a drawback to this design. Since it was flat, it would easily bend in the vertical direction, but not to the horizontal direction. So when you rotate the wire 360 degrees where the blood vessel bends, and the wire is bent along with it, even if you try to rotate it, the wire doesn't turn. If you really push, it will finally start to turn. It's bent like this, and when you rotate it like this, the wire is already subjected to the maximum load. You add just a little more and the wire suddenly whips. Physically, that's just what naturally happens. This is the definite drawback to this wire structure, especially for CTO wires. This is why even though the Miracle was a revolutionary wire, it still had a definite drawback because it had the same structure as the conventional wires. That was the first improvement with the Conquest. The reasonable solution for anyone who thinks about it would be to create a wire structure with a round core, however. The problem with that is that this core would bend in any direction. What I mean is, when the wire is overloaded, it tends to bend in any direction. What is particularly problematic is when the wire ends up with a 3D deformation, like an S shape. When this happens, the wire cannot be maneuvered at all. That is the biggest drawback. So to improve this, we increased the tip load. By increasing the diameter of the core at the tip, we prevented this from occurring. So from the very beginning, the Conquest was a wire that was destined to be. We couldn't lower the tip load past a certain point, so we had to make the core larger. The result was the Conquest wire. Another feature of the Conquest is that it's a tapered wire. By tapering the wire, the tip naturally becomes thinner. This is, of course, advantageous for penetration. We had known this for a long time, so that is the structure used for the Conquest wire. I think this was probably at the request of Dr. Kazuaki Mitsudo. This change made the difference in maneuverability between the Conquest and the Miracle. In other words, as I mentioned, the greatly improved tractability at the wire's tip. People focus only on how well a wire with a high tip load penetrates as a reason why the Conquest became so widely used later on. But really, this wire realized significant progress in maneuverability. The Miracle has a great deal of torque, but it is a wire that takes getting used to, with a great many idiosyncrasies. So in order to handle the Miracle wire well, you have to have a certain level of skill in maneuvering wires to be able to make the most of it. But the Conquest doesn't have the unevenness in rotation that I mentioned earlier. So it's a wire that is easy for anyone to use. The tip responds in the way you want it to. I personally think that's one of the main reasons why the Conquest became so popular around the world. Once this wire was actively incorporated into the parallel wire technique and it was used in CTO treatment, it had as much of an impact as the Miracle did when it was first introduced to CTO treatment, boosting the CTO success rate even higher. In 1997, Dr. Osamu Kato and Dr. Nicholas Reifert developed the parallel wire technique for CTO collaboratively. On the basis of development of the Conquest wire, the parallel wire technique was recognized as a more effective treatment method. In 1998, in order to make use of the parallel wire technique more widespread, Dr. Osamu Kato held the first CTO Club meeting at Kyoto Katsura Hospital. This meeting has been held in Nagoya every year until now. When I came back to Japan, I looked at improving the parallel wire technique and did a lot of research on how it could be used more effectively with CTO. I held the first meeting of the CTO Club. The club was to promote the parallel wire technique, and we held the first meeting in Kyoto. The CTO Club continues, of course, but that was how it was founded. When we founded the club, Dr. Mitsudo was working with ASAHI INTECC to develop the Conquest wire. As part of the development process, ASAHI INTECC would supply the Conquest wire to me. This wire came to be adopted for the parallel wire technique. The fact that the Conquest wire functions so effectively with the parallel wire technique for treating CTO led to the first meeting of the CTO Club that I mentioned earlier. In 1999, the second CTO Club meeting was held at the Cardiovascular Center, Kyoto Katsura Hospital, and a live demonstration of CTO procedures was carried out by Dr. Takahiko Suzuki, Dr. Hideo Tamai, and Dr. Osamu Kato. After the live demonstration, Dr. Kato performed the retrograde approach with the collateral channel for the first time, and thus confirmed the feasibility of using the collateral channel as the retrograde approach route. In the mid-1990s, the idea of using the septal channel as a means of access route in a retrograde method came up, and Dr. Tamai and I talked about this around 1995 or 1996. However, this was just a talk because we agreed that it was a high-risk procedure. However, we did a live demonstration at the CTO Club in 1999, and the patient suffered a reocclusion, not during the demonstration but afterwards, and I had to reattempt the procedure at a later date. At that time, the septal channel was extremely large, and I used the septal channel to access the occlusion site with the retrograde approach. We were aware that the septal channel was the best chance of making the retrograde approach possible for the treatment of CTO. Although bare metal stent, or BMS, was launched in the 1990s, problems with stent restenosis meant that catheterization was considered to be inferior to CABG. However, in the 2000s, numerous reports of clinical studies carried out using DES were published, and these showed that the restenosis risk, which was high with BMS, had been reduced by 70%. It is therefore clearly possible to improve the long-term outcome of catheterization. It had been reported that DES implantation improves the long-term outcome of PCI for treating CTO, and it was expected that for improvements in initial outcome, revolutionary progress would be made with CTO procedures and its devices. One particular outcome of this was that it became usual for CTO sessions at overseas conferences and live demonstrations to be fully crowded. The third CTO device development boom started in this context. In 2001, the CCT conference, which was organized mainly by Dr. Takahiko Suzuki, Dr. Hideo Tamai, and Dr. Osamu Kato as one of the world's 3 main live demonstrations, was held. Live demonstration of the retrograde approach, to which Dr. Osamu Kato had given attention from the point of view of revolutionizing CTO procedures, was carried out for the first time in the world. In 2003, ASAHI INTECC signed an exclusive sales agreement for the PCI guide wires with a major healthcare company in the United States, Abbott Laboratories. Miracle and Conquest were then launched in the United States. In 2003, when ASAHI INTECC's PCI guide wires were launched in the United States, Dr. Martin B. Leon held the CTO Summit in New York, primarily for the domestic physicians. The 5 Japanese physicians performed CTO procedures in the conference. The success of these procedures using ASAHI INTECC's PCI guide wires provided them with an opportunity to capture the spotlight. In 2003, as a live demonstration at Toyohashi Heart Center for TCT held in Washington, Dr. Osamu Kato carried out a CTO PCI in the left main trunk using the retrograde approach. After the live demonstration, it was found that the septal channel used as the route for the retrograde approach had been dilated due to the passage of the catheter, and it was surmised that the septal branch had been expanded by the balloon. The principle of low-pressure inflation of the septal channel using a balloon with a small diameter of 1.25 millimeters was established and was reported as the septal channel dilation technique in 2005. At the same time, the concept of controlled antegrade and retrograde subintimal tracking, or CART, was established as a technique for reliable passage through CTO by the retrograde approach. In 2003, I went to Toyohashi to perform the procedure on a live demonstration broadcast to TCT. This case involved a total occlusion in the left main trunk, and there was a very large septal channel from the right coronary artery. I was able to bring a wire retrogradely and pass it through without a problem. It was a very special case, and I was not generally talking about using the retrograde approach. But this technique was very rare in the Western countries, so they were extremely interested in seeing it demonstrated. But more than that, after passing the wire through the septal channel, you of course have to bring the catheter in from the right coronary artery. After the demonstration ended, all the catheters were removed, and of course we took an angiogram. The angiogram showed the septal channel, which had been quite large at the start, had been further enlarged due to the Dotter effect that occurred when the catheter passed through. Seeing this, I thought we might be able to dilate the septal channel. So that is where we began the attempt to figure out how to dilate the septal channel. At the same time, no one understood why a bilateral or bidirectional approach worked better for passing devices through CTO lesions. Of course, coronary arteries and iliac arteries have completely different diameters, so it's difficult to imagine using the same mechanism for both. In 2004, while treating CTO at a hospital in Nara, Dr. Osamu Kato had an experience with a case involving wires inserted in the antegrade and retrograde directions, forming knuckle-like shapes and meeting in the subintimal space. Due to the knuckle-like shape of the retrograde wire, a communication aperture between the subintimal space formed by the antegrade wire and the distal true lumen was expanded, enabling the antegrade wire to be passed through easily. This case was taken as the prototype of CART technique. There was a relatively young patient at a hospital in Nara. For the treatment of CTO in the patient, we used the retrograde approach and inserted wires from both directions, and the wires became knuckle-shaped. Because of the knuckled wires, The subintimal dissection space was dilated from both directions in the coronary artery. However, since we were using the knuckle wires from both directions, the subintimal lumen was automatically communicated. The wires just passed through on their own. So with the subintimal lumen, a double or triple lumen wasn't possible. Once it's done, it can only be made in that particular spot. In other words, I realized that if you made subintimal lumens in 2 or 3 places, they would automatically link up as they were dilated. The CART technique was established based on this realization. Of course, IVUS was increasingly being used in CTO treatment, and we knew enough by then about what was going on inside and what the lesions were like that it was possible to develop the CART technique. In about 2002, Dr. Osamu Kato had the idea of treating CTO using an OCT imaging wire and requested ASAHI INTECC to develop a penetration catheter for making a hole in CTO lesions. The resulting product, Tornus, was launched in 2004. In September 2004, Fielder was developed and launched as a guide wire with a wide range of effectiveness. It shows improved torque response, lubricity, and vessel selectivity.